Hello everyone. We will discuss radiological approach to acute abdomen. Acute abdomen means acute pain in abdomen, sudden onset of acute abdominal pain. Why we want to discuss this? Because radiology play a very important role in reaching diagnosis and guiding treatment. So acute abdomen by definition is acute abdominal pain in seriously ill patient who show guarding on palpation. For this discussion, we will just consider acute abdomen pain who require imaging diagnosis. Early days before imaging, all patients who showed guarding would have undergone surgery, but now with imaging, some patients will not need surgery who show guarding also. And opposite also, if there is no guarding and if there is pain in abdomen, like in appendicitis, they will need surgery. So imaging plays very important role in diagnosis, and in most of the patient, imaging will be required to reach the diagnosis. Obviously, careful medical history, physical examination, lab investigation will help. Common causes are ureteric colic, acute appendicitis, cholecystitis, pancreatitis, obstructive jaundice, bowel obstruction, diverticulitis. Less frequent are perforated viscous and bowel ischemia. In females, ovarian torsion and ectopic pregnancy. For ovarian torsion, early diagnosis is required to save the ovary. Ectopic pregnancy, we should ask for the history of missed menses in childbearing patients. What are the radiological modalities available? Radiography, sonography, contrast in CT and MRI. We will see role of each. Radiography, we have two options, chest radiograph and abdomen radiograph, which can be done. It is important in two conditions like bowel obstruction and perforated viscous. Otherwise, most of the time it provides very little information or no information. Bowel obstruction patient will present with acute abdomen pain, increasing abdomen girth, constipation, vomiting. Perforated viscous patient will present with severe abdomen pain, guarding, and most of the time patient will be seriously ill. This is a frontal chest radiograph in erect position in a patient who presented with acute abdomen pain, and it is showing gas under diaphragm. So the diagnosis is perforation. What CT can tell more is the site. In many cases, it can tell the site of the perforation. Two common sites are peptic ulcer disease and diverticulitis. CT is also very sensitive even for small free intraperitoneal air. This is a frontal radiograph of abdomen. It is showing dilated small bowel loops centrally placed and they show valvulae convenientis because they traverse the whole thickness of the bowel. Opposite to that, large bowel will be peripherally placed and they will show incomplete markings and they are called hostra. So this is a dilated small bowel loops which are centrally placed and show the full thickness small bowel folds. And they are dilated because they are more than 3 centimeter. We should remember the 3-6-9 rule, 3 for the small bowel, 6 for the large bowel and 9 for the cecum. If they are dilated more than that, we call it dilated. So it is nothing but a small bowel obstruction. Then ultrasound is usually the first investigation which is done in acute abdomen patient. Most of the time it will be sufficient and no further test will be required, like in ureteric calculus, cholecystitis, pancreatitis. In pancreatitis, most of the time clinical and lab like serum amylase lipase level will give the diagnosis. In appendicitis, WBC count will be raised, and in these cases, ultrasound will give answer in most of the patients. Very rarely we need CT for further investigation if ultrasound is insufficient or not giving any answer. Contrast intensity is the most accurate, but the disadvantages are radiation and contrast in impaired patient because it contains high limited contrast and it can lead to increase in the renal impairment. One drawback, we can say approximately 20% of the gallbladder CBD calculi are not seen on CT because they don't contain calcium. But for ureteric colic, ureteric calculus, renal calculi, there is no problem with the CT. MRI has very limited role in acute abdomen and it has a peculiar role like in pregnancy where CT is contraindicated and ultrasound is not giving any answer, or in impaired renal function, non-contrast MRI can be used. And if sonography is not giving any answer and there are HBR and CBD dilatation, and because of boil gases, CBD calculus cannot be seen, then MRCP can be used. So to summarize, clinical examination, history, physical examination, few lab investigations are very important. Radiography can diagnose bowel obstruction and perforation. UH is the first and most of the time sufficient. Contrast and non-CT abdomen is the most accurate, and MR has limited role in acute abdomen. So we will see few common cases. Acute appendicitis history will be typical. There will be periumbilical pain and which will migrate to the right iliac fossa. There will be tenderness in the right iliac fossa. UAG will be sufficient in most of the time. CT, if UAG is inconclusive, like in obese patient or patient is showing gaseous distension of abdomen. This is the ultrasound image showing the swollen appendix and adjacent inflamed hyperechoic fat suggestive of acute appendicitis. This is the axial CT image showing swollen appendix and inflamed adjacent fat standing. This is normal hypodense fat, you can see. Ureteric calculus, typically patient will have loin to groin pain radiating, some urinary complaints, vomiting will be there. UAG is sufficient most of the time. CT has limited role. This is a kidney showing dilated pelvic acyl system ureter and there is calculus here in the path of the ureter. Pancreatitis, epigastric pain severe, then on lab there will be raised serum amylase lipase level. USG is the first investigation to be performed. CT will add some value in the form of guiding the treatment and staging the disease and to detect the complications like necrosis, vascular complication, and some delayed complications like pseudocyst and walled-up necrosis. This is axial post-contrast CT image showing destruction of head and body of pancreas and which is replaced by this cystic structure, and this is walled-up necrosis. Here this is coronal post-contrast CT image showing the pancreas and adjacent inflamed fat. This is a normal hypodense fat, but fat here is inflamed, fat standing is there. This is the pancreas in the center, and this is the portal vein showing a film defect, and this is the portal vein thrombosis. So, CT will tell you the complications like aneurysm also. Cholecystitis, patient will be presented with acute abdomen pain, tenderness in right hypochondriac region. USG will be accurate and sufficient in most of the patients. This is ultrasound image showing the gallbladder calculus impacted in the neck. Show wall thickening and adjacent inflamed fat will be there. There will be throat tenderness in that region. CT can give some answers like complications, perforated and gangrenous cholecystitis. Then CBD calculus, patient will present with acute abdomen pain, vomiting, and on lab there will be raised level obstructive jaundice will be there. USG will give answer most of the time. This is a dilated CP and there is a calculus sitting in the path of the CBD. If not, then MRCP is the ideal, but affordability is again an issue. CT is less sensitive for gallbladder and CBD calculi because they don't contain calcium that much. This is MRCP image showing gallbladder and dilated CBD and filling defects. They are calculi sitting in the CBD and dilated IHBR in the liver. Dilated intrahepatic biliary radicals. Bowel obstruction, small versus large bowel. Small bowel obstruction. Common causes are adhesions, neoplasm, hernia like inguinal, internal, rarely inflammatory disorders like Crohn's disease. Small bowel can be diagnosed on radiograph, but CT will be required to tell the site of the obstruction, cause of the obstruction, and the severity of the obstruction. We discussed this 369 rule. This is a coronal CT image showing dilated small bowel loops, and you can see the transition point. Transition point is the point where proximally there are dilated bowel loops, and distally there are non-dilated collapsed small bowel loops. And most of the time, common cause is adhesion. In adhesion, there will be sudden abrupt change in the caliber as well as there will be kinking. Adhesions cannot be directly seen on the CT. It is most of the time diagnosis of exclusion. This is a coronal CT image showing dilated small bowel loops, and this is the colon which is non-dilated collapsed. So this is a small bowel obstruction, and you can see the mass, the small bowel which is causing the obstruction. Then coming to the large bowel obstruction, common causes are colorectal carcinoma, sigmoid volvulus, diverticulitis. This is the axial CT image showing dilated descending colon, and this is the cecum which is usually dilated, and there is a focal wall thickening at sigmoid colon, and it is showing shouldering at the margin, and it is focal, and it is very suspicious for typical of neoplastic lesion. Perforation radiograph can diagnose in many patients. CT is more sensitive for small free intraperitoneal air. CT can tell site of perforation in many patients. Common causes are peptic ulcer and diverticulitis. Coming to the diverticulitis, CT is the modality of choice. It can confirm the diagnosis and stage the disease, which can assist in therapeutic decision. This modified Hinchey classification is used to treat the patient. Mild clinical diverticulitis without abscess or peritonitis will be treated conservatively, but if the patient is presented with distant intraperitoneal abscess and peritonitis, patient has to undergo surgery. This is a sagittal CT image showing the colon here, and these are the air-filled outpouching arising from the colon, and they are diverticuli. They are commonly seen, particularly in elderly patients, but they are not inflamed here. But this in this axial CT image, in another patient, you can see multiple diverticuli, and there is a wall thickening and adjacent fat standing. So it is a diverticulitis. There is no perforation, there is no abscess, there is no peritonitis. Can be treated conservatively. Epiploic appendicitis is the inflammation of appendicitis epiploicae, which is a fat anterior to the colon. Typical clinical symptom is like patient can tell the exact site of pain by his finger, and at that position there will be inflamed fat on sonography, and on CT there again will be inflamed fat like this, fat standing localized anterior to the colon here. So this is epiploic appendicitis. Bowel ischemia, CT is the modality of choice. Ultrasound can sometimes diagnose on color Doppler. There won't be flow on the supramesenteric vein or artery. Most of the time, because of bowel gases, it will be less sensitive. The axial CT image showing contrast enhanced CT image showing filling defect in the supramesenteric vein. And you can see the bowel here, which is thickened and show less enhancement as compared to this normal enhancing non-thickened bowel. This is the other patient post-contrast CT image showing filling defect in the supramesenteric artery while the supramesenteric vein is normal. So bowel ischemia can be caused by vein obstruction or Arterial obstruction. Arterial obstruction patient usually need surgery. Supramesenteric vein thrombosis can be treated conservatively with anticoagulants. And if the bowel ischemia progress and gangrene happen, there will be intramural air in the wall of the small bowel and which can traverse through the portal vein into the portal vein branches in the liver. Then this is a patient, 30-year female patient who presented with acute abdomen pain in lower abdomen region. On sonography, the ovary is swollen and it is shifted towards midline. Color Doppler, there was no flow, which is a very bad sign because most of the time ovary will be necrosed, so it is nothing but ovarian torsion. This is another patient who presented with abdominal pain and missed menses history, and if it positive, on carefully seeing transvaginally, you can see right abdomen region, extra uterine, extra ovarian, and this is called tubular ring sign, and it is nothing but ectopic pregnancy. So, few points to remember. USG is the first investigation in acute abdomen. Most of the time will be sufficient. Contrast intensity is most accurate. Radiography will play a role in few like perforation and bowel obstruction. And MRI has few role like when the sonography is not giving any answer and CT is contraindicated, and it has some role in CVD calcular diagnosis because CT will be less sensitive for gallbladder and CVD calculus because they will not have that much calcium. Thank you.